Good afternoon, everybody. So all I'm here to say is that no learning is complete if we don't learn from our mistakes. So at the outset, I'd like to thank my mentors, Dr. Honavar and Dr. Shields, who's taught me everything that I know about ocular oncology and some great cases that I'm happy to share here with you. So we're all happy that retinoblastoma is one of the most curable cancers. Slides are not moving. But the key is that it needs to be correctly diagnosed and treatment has to be started promptly. So we heard from Dr. Vijita what retinoblastoma looks like, especially in all the imaging modalities, and we're familiar with what it is now. But it is also important to know some other lesions that can occur that can look confusing, that you might think is retinoblastoma. So it's always important to think, if it is not retinoblastoma, what is it? Is there anything atypical about these lesions that you're seeing? Am I missing any systemic condition? And who should I refer to? So my job real quick is to show you some cases of pseudo-retinoblastomas and also some what to do's and specifically some what not to do's when dealing with these tumors. So this was a 6-year-old Caucasian boy who failed his vision test in the left eye and was found to have this retinal lesion. There's no family history of retinoblastoma. So what do you think? Is this a case of unilateral retinoblastoma? No seeds, so probably a group B. So ideally, one would plan intraarterial chemotherapy as the most, ideal treatment modality, or if not, affordable chemotherapy. So what do you think? So let's take a closer look before we make any decisions. It's not moving again. So when we look at the ultrasound, we see this echo-dense lesion, no real calcifications within. But look at the OCT, what you see here. Dr. Vijita briefly mentioned this. So you see these cavities within the tumor. These are microcalcifications with a typical moth-eaten pattern. Let me show you another image of the same lesion taken towards the edge of the tumor. Here you can see where the tumor is actually arising from, and you see that it is from within the nerve fiber layer. So arising from nerve fiber layer and moth-eaten pattern, this is very typical of retinal astrocytic hematoma. And this is not retinoblastoma. Astrocytic hematomas are benign glial tumors. They are unilateral in 85% of the cases. They can have subretinal fluid, cystoid macular edema, and cavities. And they can also have calcifications in 60% of the cases, at which it can be tricky and you might think it's retinoblastoma. So can retinoblastoma have cavities? This is a case of retinoblastoma. They can also have cavities, as you can see here, which is more evident in ultrasound and in MRI. This is an entity called cavitary retinoblastoma. But in these, the cavities are slightly larger and don't have the typical moth-eaten pattern. So coming back to astrocytic hematoma. So here, astrocytic hematomas are associated with tuberous sclerosis in 20% of the cases. So that is the importance of knowing about this entity, especially if you're a pediatric ophthalmologist and if you see cases of ocular tumors. And when associated with tuberous sclerosis, they're often multiple and bilateral. As you can see here, again, if you look at an OCT, if you can quickly get one done, you see that these arises from the nerve fiber layer. So what's the importance of knowing this? So if your child comes to you with astrocytic hematoma and you suspect tuberous sclerosis, they are much likely to have other features, systemic features like epilepsy, intellectual disability, subependymal astrocytomas in the brain, and renal angiomyolipoma. So it's important to look for other neurocutaneous markers like facial angiofibromas and hyperpigmented macules on the body to make this systemic diagnosis and properly refer to a pediatrician and for genetic analysis. So we'll move on to something that you may encounter more commonly. This is a 1-year-old boy referred with white reflex in the right eye with a suspected mass in the MRI. He was treated with 5 cycles of chemotherapy for retinoblastoma and finally referred to us because there was no response in the lesion. So if you see here, the reflex is more yellowish than a whitish reflex. And you look closely, you see these telangiectatic vessels. And if you look at the tips of those, you will see light bulb telangiectasia, as we call it. And this, as you may know, is typical of Coats disease. And in earlier stages of Coats, you treat symptom, you can treat with cryotherapy and laser. Some may have really good response. In advanced cases, you may tailor your treatment more towards symptomatic management or cosmetic concerns. You may choose to enucleate and provide an implant and prosthesis. So the important thing is to look at the reflex and see whether it is a white reflex or a yellowish reflex. In coats, you normally find a xanthochoria or a yellowish reflex because of the dense exudates. In retinoblastoma, it's more of a white reflex or leukochoria. So this is a 14-year-old male, an older child with decrease in vision in the left eye with retinal exudates. Looks typical of Coats disease, but if you look closely at the periphery, you see this elevated retinal lesion. So there's a mass associated with it. Now this may confuse you. Do you think it's actually retinoblastoma or some kind of retinal tumor with associated exudate? No, so this is also Coats. If you look at the angiography, you'll see the typical telangiectasia, especially the light bulb telangiectasia. So the mass that you saw is actually a secondary vasoproliferative tumor, or VPT as we call it, which can be associated with inflammatory and exudative conditions of the eye. So this child was treated successfully with cryotherapy and argon laser photocoagulation to areas of non-perfusion, and he did very well. So some associated features in Coats, which is a common condition and important for everybody to know, can throw you off. So this is also a case of Coats, but if you look carefully, there is a cystic lesion over there. So these are subretinal cysts, which again can be more evidently seen on ultrasound and on CT scans, and this can coexist with Coats disease. Now, I'd like to thank Dr. Vijita, Dr. Kaliki, and the LBP team for sharing this case with me. This patient presented to the LB Prasad High Hospital. This is a 4-year-old boy with blurry vision in the right eye, and fundus shows this mass at the fovea. So you see here, again, telangiectatic vessels and exudates around this mass. So you would think Coats, but what about this mass? You see a mass with Coats right at the center and the macula. So if you look at the ultrasound, you see the elevation, echo dense, no calcifications. And if you look at the OCT, you actually see the lesion to be under the retina. It's a subretinal nodule lifting the retina up. So this is a gliotic nodule, which also can be associated with Coats disease because of chronic inflammation. Again, the bottom line here is when you see all of these, not retinoblastoma, does not require chemotherapy like the first child that I showed. Now here's an 8-year-old boy who was referred to us with white reflex nasally to see if it is retinoblastoma or not. But before this child presented to us, the child had actually been through a lot. So if you see, this child has these corneal sutures. He had undergone iris cyst excision. I don't know if a biopsy was sent. Later, he was found to have neovascular glaucoma. He underwent a glaucoma drainage implant. You see the implant over there with the tube in situ. If you look carefully, you see this vessel, so sentinel vessel going towards the infranasal limbus. Take a closer look, you see this lesion arising from the ciliary body. So it's important to know about this entity. It's slightly rare, but after retinoblastoma, the other intraocular tumor you think of in a child is a ciliary body medulloepithelioma. Now, it's important to know this because unlike retinoblastoma and Coats that you kind of get to see clearly or right at the posterior pole and it's quite evident, ciliary body medulloepitheliomas tend to be hidden because it arises from the ciliary body and it's not diagnosed till it's very late. And when I say very late, what happens usually is they develop a cataract, especially because it butts onto the lens, starts off with a focal cataract, becomes a mature cataract, presents with a white reflex. They go on to, they can have cysts that can detach from the tumor and float in the vitreous, and they develop neovascular glaucoma. And this entity specifically is notorious to present to an ocular oncologist after having had cataract surgery and glaucoma drainage devices implanted in up to 80% of the cases actually. So this is important to know. Again, this is another case of ciliary body medulloepithelioma. You see a whitish reflex and you see these new vessels forming. You can see the mass behind the iris forming a focal cataract with neovascularization. So it's important to know this and refer promptly before invasive procedures are performed because these can also grow and become an extrascleral extension. This is a child that came to me last year. This is not orbital retinoblastoma. This is a case of an extrascleral extension of a ciliary body medulloepithelium. I think Dr. Anirban helped manage the case. You might recognize the child from Bangladesh. So the bottom line is that when an adult presents you with neovascular glaucoma, your top differentials are sequelae of CRVO, PDR, ocular ischemic syndrome, and then you think of tumor, maybe a melanoma in an adult. But when a child comes to you with neovascular glaucoma, I would say your top 3 differentials should be tumor, 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 and do everything you can to rule that out before you do any invasive procedure, and then you think of other causes. Can children have melanoma? So this is a 9-year-old girl who presented with total retinal detachment, but you don't see a whitish or a yellowish reflex. You see nasally that there is a brownish mass underneath the retina. MRI shows hyperdense lesion, hyperintense large lesion in the eye nasally. Ultrasound shows no calcification, but you can see the large lesion. And on enucleation, this was a large melanoma in a child. So very rarely children can also have melanoma. So this is another entity, more commoner, especially pediatric ophthalmologists might encounter. You might guess by one look at it, white reflex, thick on UBM, there is shallow anterior chamber. This is a severe case, so there's iris Bombay formation. You see this thick layer in the pupillary area over the lens, and on angiography you see tunica vasculosa lentis. There's also associated microphthalmia. So this is a clear case of persistent fetal vasculature, persistent hypoplastic primary vitreous, where you can again manage symptomatically or towards cosmetic concerns. Again, not a malignancy. So here's a quick case of a 7-year-old Hispanic girl referred for retinoblastoma in both the eyes. So she had bilateral tumors, small tumors, but when we looked at the child a little closely, the child was rather drowsy, had a down gaze, was quite lethargic. So these should raise a red flag and immediately get an MRI done. This child had a large cellular lesion. So in this categorizes this as a trilateral retinoblastoma. And as you know, trilateral, in 75% it's in the pineal gland region, but in 25% it's in the cellular or supracellular region. So it's important to pick up these subtle symptoms in these children. Just gonna skip this. So I'll end with just few cases of what not to do in retinoblastoma. This is a 2-year-old girl who was actually found to have a white reflex by her parents, a while ago. Was taken to a local doctor. Was told to have a dense cataract and associated vitreous hemorrhage. And the child underwent cataract surgery, vitrectomy, endo laser, silicone oil infusion, oil exchange, C3F8, all of that. And then later, much later, presented to us with this painful proptosis in the eye. So if you see, there's corneal sutures from previous procedures, there is a hyperpion probably mixed with tumor, and you see this nodule over the sclera suggesting extrascleral extension of retinoblastoma. And also on CT, you can see calcifications within the eye, and she also had a posterior orbital extension of this tumor. Unfortunately, by the time the child came to us, she had large preauricular lymph node metastasis. She also had bone marrow metastasis. So this is a devastating case, and this should never happen. A similar child had a trivial trauma, was taken to a hospital because of blurry vision, was told to have traumatic uveitis, but as you can see, these are retinoblastoma seeds in the anterior chamber. And he was told that there's traumatic uveitis and vitritis, which was just not resolving with topical medication. And he was taken up for vitreous biopsy and Ozurdex implant. You can see the biopsy site, and that site needs to be watched very carefully, treated with cryotherapy. And on fundus examination, you see these tumor clouds with the Ozurdex implant, which was not necessary, and it is just a misdiagnosis. So these kind of things should not happen when you see a child, because normally a child, you can have vitreous hemorrhage in newborns, but a normal child normally will not present with cataract associated with vitreous hemorrhage, and uveitis just is not resolving just because of a trauma. So these should raise red flags. So we all know that when in doubt, we always should ask or refer, but with children with ocular tumors, all of us, general ophthalmologists, oncologists, retinal surgeons, pediatric ophthalmologists, we should all remember that when in doubt, we should not risk life.